I'm Davin Quinn. I'm the Division Chief for Behavioral Health Consultation and Integration. And it's my pleasure to introduce today's Grand Round speaker for our Department of Psychiatry and Behavioral Sciences. This is Dr. Robyn Bartel. And I'll just share with you a little bit of information about Dr. Bartel and her background here. She's a fourth-year psychiatry resident at the University of New Mexico. She is the current Consultation Liaison Psychiatry Chief Resident, is doing an amazing job on that service right now. And she also served as the Community Psychiatry Chief Resident in her PG 3 year. So, doing a lot of chiefing for the past 2 years. Dr. Bartel graduated summa cum laude from Barrett Honors College at Arizona State University with a Bachelor's of Science in Biological Sciences and a minor in psychology. She attended medical school at the University of New Mexico before joining the residency program here, and she is currently applying for additional fellowship training in consultation liaison psychiatry. I want to say that she also recently presented her work, her research at the annual Academy of Consultation Liaison Psychiatry annual meeting for 2025, which was held in San Antonio last month. So she's going to be sharing some of her findings from her research here with us today. Really sort of grateful to Dr. Bartel taking the time to prepare this talk and to educate us. So um, please proceed with your talk, Dr. Bartel. The floor is yours.
Thank you, Dr. Quinn. Let me share this again. All right. Oh, it asked me if I wanted to continue. So my talk today is about the post-acute sequelae of COVID-19 with a specific focus on neuropsychiatric symptoms and treatment. Obviously, for the Department of Psychiatry, we're particularly interested in that. And so my learning objectives are to go through an overview of a current understanding of the pathophysiology of post-acute symptoms of COVID-19, with a focus on neurocognitive dysfunction, understanding a range of the treatments for these neurocognitive complications, and then discussion on specific outcomes with the use of stimulants in the treatment of long COVID. I have no disclosures. So I first wanted to go through some terminology, in part because I've already used multiple terms for the same thing, which is long COVID or post-acute sequelae of COVID-19. Depending on what paper you're reading, who you ask, they seem to be interchangeable terms. Here in the US, that means a syndrome in which there are persistent symptoms post-COVID infection more than 28 days after initial viral infection. Around the world, this is a different definition. And so in Europe, for example, they use a 3-month cutoff instead of a 1-month cutoff, which may impact some of our numbers and what we see versus what people in other countries see. And part of this long COVID syndrome is a neuro post-acute sequelae of COVID-19 or PASC. And this is post-COVID cognitive dysfunction. And so that's with neuropsychiatric symptoms, and that's in about 35% of people with PASC, and that's US numbers. In the US, the general number of people with long COVID is about 14%. Difficult because the prevalence is changing over time. And so it's becoming less common with the newer variants, which is good. With immunization, get your boosters, everybody. And as we treat with antivirals, with COVID infection, it's more common in somebody who's been severely ill with COVID, so in the ICU, people who are older, women, people with any sort of medical comorbidities, and people who are unvaccinated. And then the general thought behind this syndrome is that it's multi-system tissue damage. And so it can impact pretty much every organ system in the body. It can cause reactivation of latent viruses, so things like herpes or Epstein-Barr. It can cause coagulation dysregulation, so people have DIC. There's autonomic dysfunction. There's dysfunctional nerve signaling. There's GI dysfunction, vascular dysfunction, and then there's molecular mimicry of the virus and our own immune system. And so there's immune changes as well. And this looks very like other post-viral syndromes, as well as things like myalgic encephalitis or chronic fatigue syndrome. And so there's some overlap in this syndrome and later in terms of treatment. And then if you really want to get into it, there's a little bit more in the basic science where you have specific the viral binding to the ACE2 receptor, and that will come back later, so important to remember. And so that is suspected to be the mechanism of cellular binding, also this molecular mimicry, and this triggering of immune dysregulation can cause a cytokine storm, and so over releasing of immune modulating agents, and so general dysfunction throughout the entire body. More specifically, the neuropathophysiology, so what we're more likely to be treating in this department. And so I'm going to go through some of these in more depth, but there's no consensus on which specific area is the reason why there's neurological symptoms, but there's suspicion that it could be either a combination of or maybe all of these things. So some of the hypothesized mechanisms are CNS infection through the olfactory nerve, blood-brain barrier dysfunction, autoimmunity, mast cell activation, neuroinflammation, gut-brain axis dysregulation, and vascular disruption. So a little bit more depth on this, and I particularly find this one interesting, the direct infection through the olfactory nerve. This is retrograde viral transmission. This is similar to the retrograde viral transmission that's seen in herpes virus and also in rabies. And so there's the suspicion that through, again, this ACE2 receptor that is on olfactory neurons, that COVID virus can bind to that. And through synaptic connections will directly invade the CNS, which is not a desired outcome, is to have viral infection in your CNS. And so there's some more there's hypotheses about which cells are involved. Is it the horizontal cells? But I think generally for our understanding of this, that the virus is able to directly infect the central nervous system. And it's interesting as well, this idea of direct viral connection with the olfactory nerve, because of course we all know the anosmia that's associated with COVID is one of the symptoms that everybody was most concerned about, I think, in terms of long-term quality of life. And so it's interesting to me that there's also this connection with the virus directly binding to this nerve. Other proposed mechanisms include the blood-brain barrier dysfunction, and so this is hypothesized to be due to systemic inflammation, which leads to this direct invasion again of viral cells into the central nervous system, that the systemic inflammatory markers that were released in this general inflammatory response increase the permeability of the blood-brain barrier, and that this can again, sort of directly invade. And then there are, again, these ACE2 receptors on astrocytes. And so another harkening back to a way for this virus to bind to our cells. Autoimmunity, so this is, again, something we talked about a little bit briefly, but there's a significant molecular mimicry with the COVID virus and our cells. And so there's enough similarity of the proteins on the COVID vaccine, or the COVID virus and our cells that you can see a production of these antineuronal and autoantibodies. And there's enough overlap that leads to an autoimmune reaction. There's also gut-brain axis dysregulation. And so this was in a mouse study, not humans, but they found that there's a decrease in the good bacteria. So the bacteria important for the gut-blood barrier. And then this can lead to inflammation and also viral invasion. And then vascular disruption. And so with kind of the immune response, there can be microvascular damage, general endothelial dysfunction, which leads to vasoconstriction. Not so good for one's brain to have hypoperfusion, and that's seen in vasoconstriction when it's not physiological. And so this is also sort of hypothesized to be part of the neurologic reason why we have these symptoms. And then sort of more specifically neuroinflammation. And so the virus, however it gets into the brain and into the body, it can cause immune system reactions. It is sort of a vicious cycle with immune release, and as there's more immune release, then more cytokines get released. And as this is happening in our brains, it activates the microglia, and this reactivity can impact astrocytes, and this causes inflammatory markers to be released. And when those interact with our neurons do not survive well when they have these cytokines. And so there's neurotoxicity from these. And then I think it's become perhaps hopefully more thought about, but mast cell activation as a complex and a part of why we have these autoimmune responses and then these inappropriate immune responses. And so it's suspected that COVID can lead to this multi-system inflammatory response through activation of mast cells. And then the mast cells cause this sort of cytokine storm, and then it causes theoretically a more immune response. Thinking of the symptoms we're looking at, so we have all these mechanisms, but what are we looking at in terms of patients that we see? So these are numbers from a European study, and so this is 3 months after COVID infection. So, take that with a grain of salt. It may not be the US guidelines. However, probably more likely to be patients that end up being seen in our clinics as going to be more than a month after their COVID infection. And so this was a meta-analysis of 18 studies with 10,000 patients that they came up with these numbers. And so they saw that in around 37% of the patients who had these neuropsychiatric symptoms of long COVID, they had fatigue. In 32%, they had brain fog, whatever their definition of that is. 31% have sleep disturbance. 27% have memory issues, 23% have anxiety, 22% have attention disorder, and that's one to flag. 18% have myalgia, 12% have depression, again, 12% with anosmia, and 11% with dysgeusia, and 10% with headache. And so I think things that people are going to be referred to us for are going to be things like the brain fog, probably sleep disturbance, memory issues, anxiety, attentional disorders, and depression. Probably we're not going to get referred to somebody primarily for headache, and I hope we are not. And so, we see these numbers and think, well, what do we do with these symptoms? So there's a bunch of different options for treatments that people have come up with. Most of it's based on other forms of acquired brain dysfunction, other similar syndromes, and sort of basing our treatment based on that. So one of the more promising agents that people have used, and is fairly commonly used based on the research I've looked at, are the use of alpha-2 adrenergic agonists, specifically guanfacine, and in combination with N-acetylcysteine. And so that is hypothesized to be effective because it theoretically restores dorsolateral prefrontal cortex firing. N-acetylcysteine is sort of a general anti-inflammatory, as is guanfacine, which was news to me that guanfacine was a systemic anti-inflammatory. That's also suspected to be effective in the brain, but of course, based on the overview of the pathophysiology, if we can reduce systemic inflammatory response, this can help with the neurological symptoms. We have low-dose naltrexone, so this is more like 5 milligrams as opposed to 50 milligrams, which I think we're much more comfortable using for alcohol use disorder. Especially these low doses, it's suspected to be a glial modulator, and this will decrease neuroinflammation. Melatonin, especially with that concern for sleep disturbance, but it theoretically decreases inflammatory markers and decreases cytokines, and so could also help with that general immune response. Wellbutrin or bupropion, a dopamine and norepinephrine reuptake inhibitor. It theoretically blocks hippocampal cell loss and again decreases cytokines, so it could be effective. Modafinil has an immunomodulatory effect, aside from what we would generally think of it for in terms of fatigue or neurocognitive deficits, and that it can impact the hypometabolism in the cerebral network, can impact the frontal cortex, anterior cingulate, insula, and caudate. And then stimulants. So this is sort of the general mechanism of stimulants, specifically methylphenidate and amphetamines. And so stimulants work on dopaminergic, the brain reward system, and then also on prefrontal cortex. And so that's hypothesized to be dysregulated in long COVID. And so this can help with the cognitive function difficulties, back to those 20% of people with attentional difficulties post-COVID. I have my own theories about now why we're seeing a lot of people come into our clinics with what appears to be new onset ADHD, and are these post-COVID symptoms. And so we had a case series of patients with long COVID. So they were referred to Dr. Quinn's Neuropsychiatry Clinic, and they had post-COVID symptoms, so PASC. They all had a documented history of COVID-19 infection. And then every patient was evaluated on the ADHD self-report scale, and they all met criteria for ADHD on the scale. even though they didn't previously have ADHD. 11 of those patients were initiated on stimulants. Everybody initially was started with methylphenidate. Some were transitioned to mixed amphetamine salts, so Adderall, based on efficacy, tolerability. Patients were on stimulants for a range of 1 to 21 months, with a mean of 11.4 months and a standard deviation of 7 months. 8 of the people were tolerated treatment for 9 months. And then the dose used of stimulants converted to immediate release methylphenidate ranged from 10 to 70 milligrams, so fairly high range, with a mean of 32 milligrams, standard deviation of 19. 3 of those 8 patients achieved functional recovery and discontinued the stimulants. And none of these patients develop symptoms of a tolerance or substance use disorder. There have been some studies with concern for increased risk of substance use disorders in people with long COVID. And so there's been some hesitancy around the use of stimulants for this condition. But obviously, small sample size. None of these patients had any sort of increased requirements for dose escalations, no abnormal prescribing. And again, 3 people stopped stimulants, which is not a common thing, I think, in our clinics for people to request to come off of their stimulants unless they're having significant adverse reactions. And so in that, we are concluding based on this population of people that stimulants appear to be safe and effective for this syndrome, so neuropask, and that it may assist patients in returning to prior level of function. We don't have a lot of long-term studies on outcomes from these neurological sequelae of COVID-19. And so if this allows people to return to school and work, then that could be beneficial for their return to, their lives. I think having a further patient population would be beneficial to confirm that this is safe and it's effective. And I think confirming the mechanism of action, I think there's a lot of proposed mechanisms sort of based on historical things, but we don't have enough data. We don't have long enough. And we don't know really what it is. And I think it's important to think of, and you may have wondered why this was grand rounds today, but these sort of general attentional difficulties, brain fog, sleep disturbance is a fairly common referral question, and maybe this is my N of 1 from Start Clinic, but there appears to be sort of every new referral is I think I have ADHD, I think I have new cognitive changes, and whether or not we should be doing a much more comprehensive history in terms of when did this start? Was it in relation to a COVID infection? Did it really just start in the last few years? Because that's not something that I did in my PGY3 year of trying to determine if somebody met criteria for ADHD or met criteria for stimulant use. Is not something that I was thinking of. And so I think it could be useful, especially because this is not nobody. This is a population, and they're likely in our clinics. I think it's cheering to know that the prevalence is going down with newer variants, with vaccination, with treatment. But I think it's useful to think of it in the context of how it mirrors other post-viral syndromes, so prior SARS, MERS pandemics. I don't think I'm alone in concern for a future pandemic, and so having more information, having treatment protocols in place for these syndromes with hopefully no need to use them in the future, but understanding that likely we'll need to have treatments for a post-viral syndrome. And so continuing to develop and really hone our treatment protocols is beneficial for us in the future. We didn't have as the numbers from prior SARS and MERS pandemics in order to do this level of research. And so I think this is our chance to put a nice spin on it, that we can be prepared for the future, and then also just make sure we're treating our patients to the best of our abilities. And is it really that it appears that everybody has lost their capacity for attention because they're scrolling on TikTok? Maybe. Or maybe it's because they have a post-COVID cognitive dysfunction and we haven't been treating that appropriately. And then Dr. Quinn had a plug for, so I've talked about pharmacology, but he has other plugs to make.
Yeah, thank you, Dr. Bartel. I just wanted to uh, tack on this sort of announcement about a study that we have going on. It's a treatment study for people with these neuropsychiatric symptoms of long COVID, neuropask, and the study is called Manifest, which is short for Magnetic Resonance Analysis of Neural Inflammatory Factors and External Stimulation. And so this was actually a grant that was put together, co-written by myself and Dr. Andre Vakhtine at the Mind Research Network. And we came up with this idea based on work that we had done in patients with depression, just major depressive disorder, receiving TMS. And one of our thoughts was, well, depression is sometimes associated with inflammation, levels of inflammation, and thought to play a potential etiologic role in depression. Is there a way that we can look at levels of inflammation in the brain? And he had actually developed a technique called magnetic resonance spectroscopy. I'm sorry, diffusion magnetic resonance spectroscopy, which has been shown to be able to assess the activity of microglia in the brain. And you heard Dr. Bartel speak about um, microglia potentially being sort of involved in the pathogenesis of long COVID symptoms. So microglia are everywhere in the brain, and they perform a lot of housekeeping functions. But when the brain undergoes sort of infectious or immune attack, microglia get activated. And so they're thought to be sort of a proxy for inflammation going on. We looked at whether patients who with depression who were receiving TMS had any changes in their microglia levels in certain parts of their brain. And what we found was actually some quite interesting findings that indeed there were changes in microglia going from pre to post TMS. And so that made us think potentially that TMS could be used to modulate microglia and inflammation in the brain as a treatment. And so he was doing research into long COVID. I was involved in the NIH Recover study, characterizing long COVID. And so we thought, why don't we join forces here and actually propose, looking at microglia in people with long COVID and seeing if TMS actually can improve their symptoms and reduce microglia activity. So there had only been a few case reports, case series of people with long COVID getting treatment with TMS. Those were generally encouraging. So we decided to propose this, and we received a grant to carry out this study, which you see here. So people with long COVID and brain fog, neuropask, are invited to attend a baseline visit where they have the MRI scan done as well as a clinical assessment and a cognitive assessment. And the brain scan is specifically looking at the microglia using this technique that Dr. Vakhtine devised, the diffusion magnetic resonance spectroscopy. So after they do that baseline visit, then they will get either active or sham TMS for 25 sessions. At visit two, we'll repeat all the assessments, including the scan, and then everyone will go into an open label phase and receive active TMS. So everyone will get some kind of active treatment in this study. And then after that second week of treatment, open label, they'll then repeat all the tests and the MRI scanning again at the end of the study. And then they'll be followed for 1, 3, and 6 months to see how their symptoms evolve after that. Um, so this is the Manifest study. Very excited about it as a potential sort of adjunct to the treatments that Dr. Bartel already sort of described in her talk. So if anyone has any patients with long COVID and neuropsychiatric symptoms like brain fog, fatigue, depression, anxiety, etc., please do either contact me or you have the information for our study coordinator here, Crystal Garcia, who's excellent, and we've already enrolled our first 6 participants and have got a handful more scheduled for 2026, but we're always looking for more. So that is my plug for the Manifest study. But I did want to sort of yeah, congratulate Dr. Bartel on an excellent presentation and for looking into this data regarding patients, treated in our clinic, and invite the people to ask her or myself any questions that they have about what we presented today. So thank you, Dr. Bartel, and floor is open for questions.
Oh, can I ask a question, maybe with two parts? So first, I apologize if I missed this because I might have been on a little late, but just first, like, what is like the criteria for diagnosing long COVID? And secondly, is there concern? I'm just worried, like, I know when it first came out, I would be testing my family every time anyone would have any kind of symptom. And I think we're getting away, I think a lot of people are getting away from being so vigorous about COVID testing. So any thoughts on like how that will impact the ability to make these kind of diagnoses?
I think it becomes more difficult. And so the criteria in the US are different than elsewhere, but our criteria is symptoms persisting more than 28 days after COVID infection. And so if people are obviously when you're in the throes of a viral infection, you can have symptoms, but if you continue to have either sort of generalized symptoms or develop these things like brain fog or attentional difficulties or depression, really in that very soon follow-up phase of a COVID infection, then that would be a red flag for this. And then I think obviously we're going to see that it's more difficult to diagnose long COVID if we don't know people have COVID. But I will say it's probably kind of okay in a way because the prevalence of long COVID is going down with the newer variants, with the less extreme infections, with people not being as sick from it. And so unless we get a variant that's very pathologic and we again see these sort of really massive immune responses again, I think that we're just going to see the prevalence going down. And the numbers we have are, of course, based on people who tested and knew. And so we'll just have to follow it up. I mean, we also don't see, if you have a cold and then you suddenly develop brain fog, that's not as common. And so while we theoretically have to have a diagnosis of COVID in order to call it post-COVID brain dysfunction, we can maybe hypothesize that maybe that was COVID because sort of other more common viruses that we have in our community don't have those same known post-viral syndromes.
And if I can just sort of add, I think one of the things Dr. Cullen asked is, what are the criteria? And we don't have criteria. The NIH Recover study, which is enrolling both adults and children, is one of the studies that's meant to actually be able to come up with an operational sort of definition of long COVID, including symptoms, which symptoms you need to have, how severe. So there is a study, that came out in 2024 that was called basically the update or an update on the Recover Adult Long COVID Research Index. And so it basically it asked whether you had which of 10 to 14 different sort of long COVID symptoms. And this was just to make a diagnosis of just long COVID in general. There are no definitional criteria or diagnostic criteria for um, neuropask. It's just as Dr. Bartel said, do you have neuropsychiatric symptoms and are they temporally linked? And can you make a sort of clinical link to sort of having had the infection preceding the symptoms? And for brain fog, there's no widely accepted definition either. So we're really sort of just trying to do the best that we can with what we think it is, and but we're hopefully honing in on a definition, with the NIH Recover study. So it's really to sort of say, like Dr. Bartel said, reach out if you think there's someone who might have this. Dr. Alicia Parada runs the UNM Long COVID Clinic. So she and other folks in internal medicine are seeing most of these patients for initial kind of evaluations to look at the multisystemic kind of presentation. And then if there's specific neuropsychiatric symptoms that they need our help with, they get referred to our clinic. Um, so long story short, we don't know exactly sort of, how to define this, except just to have a low threshold for suspecting it. Dr. Rose.
Hi. Thanks, Dr. Bartel. And maybe I missed it, but I was curious if you know how Paxlovid factors into this. Like if people got Paxlovid, like do they still qualify for potentially having long COVID?
Yeah, so if you've had things like Paxlovid, or I mean, other people have the direct antivirals in the hospital or the infusions, it reduces your risk, but you still can get it. So, yeah.
I would also add that there's a study that came out recently that showed that giving people Paxlovid for long COVID was not better than placebo. But being vaccinated prior to
Getting
infection
this.
does reduce the risk of long COVID.
Yeah,
Um,
everybody, as far as I'm aware, falls into that other high risk condition is when I clicked on my CVS to get my booster. So I say go for it.
Dr. Rivera.
Hi, thanks for such a great presentation, Robin. I was curious, sort of, you mentioned relying on some of the other post-viral syndrome history to try and inform treatment now. And I was sort of curious, how is that, like, a lot of that research seems to indicate that there are like flavors to these different illnesses and there's slightly different presentations, but have you found that that like anything, and this might be too early, but perhaps that some of the treatments that are being tried now for long COVID are likely to work for other people who've been gotten sick from other viral illnesses or anything like that? And maybe too early.
So I didn't study sort of other viral illnesses in particular. I think generally the hypothesis is that most of these things are generally anti-inflammatory and so would theoretically be effective in other post-viral syndromes. And in part because what we have, the body of work on other post-viral syndromes is not as extensive just because not as many people got those viruses. And so, what we have is that the symptoms are similar. And we could hypothesize that probably any sort of direct viral infection of your brain is something that causes these general immune responses would act in a similar way. There's nothing specific about COVID aside from the fact that it causes the immune reaction, and because of its proteins, does that very well. That would mean that for some reason this wouldn't work on something else.
Yeah, and just to add to to that, Dr. Rivera, there's not a whole lot of literature on how to treat other neuropsychiatric syndromes after viral infection. So I think most of what has been applied to long COVID symptoms to date has borrowed from the myalgic encephalomyelitis literature, or the ME or fibromyalgia literature. So that's where potentially medications like Abilify, which have been studied for ME, can be tried in long COVID. Low-dose naltrexone has been studied in randomized controlled trials for long COVID, and actually shown to be effective. Some of the other agents like N-acetylcysteine, that Dr. Bartel discussed earlier, but there's nothing that's really sort of like there's not an extensive literature, at least as far as medications. Now, definitely things like pacing, cognitive behavioral therapy, progressive graded, cardiovascular exercise or rehabilitation. Those are kind of considered, fairly well established in chronic fatigue and fibromyalgia, and their use in long COVID is heavily being studied and is one of generally the first line treatment that's recommended for people who come into the long COVID clinic is to get into a cardiopulmonary sort of rehabilitation program, as well as to engage in sort of pacing and sort of symptom management kind of plan. But so as far as that goes, those are the bodies of literature that people have generally been sort of looking to for inspiration for how to treat long COVID. Um, Dr. Price?
I wanted to say thank you, Dr. Bartel. That was such an interesting talk, and I think there's, um, like you were saying, a lot of evidence of other viruses that have sort of this post-inflammatory sequelae that really supports your hypothesis. I did have a question about the manifest study, and I'm asking. Is it known? So I know that chronic inflammation has been associated with depression, and I know that there's some research showing that antidepressants themselves have an anti-inflammatory effect, Dr. Quinn. But all that research was really looking at like pro-inflammatory cytokines within the body, and so I'm curious if that work has been done, sort of thinking more about neuromodulatory protocols. I know you mentioned kind of the manifest study is using a different way of assessing inflammation that's more brain specific, but I'm curious, sort of thinking about the rest of the body, if you're looking at those effects, if that's been done.
Yeah, thank you, Dr. Price. Yeah, great question. We are in fact drawing peripheral serum samples in all our patients pre and mid and post. So and sending them for ESR, CRP, cytokine panel, TNF alpha. So IL-1, IL-6, IL-10, TNF alpha, ESR, CRP, sort of thought to be kind of like the more high yield um, um, tests to look at in long COVID. And I think probably the one that maybe with the best evidence is IL-6. That said, almost all the patients I saw in my clinic had normal IL-6 levels. So we're not confident that, we're going to see actually much evidence of systemic peripheral inflammation in our patients. And this is where I think the work that Dr. Vaktin has done, is so interesting. So he actually showed in his work prior to us collaborating that in long COVID patients, that the activity of microglia assessed using DMRS in the thalamus actually correlated significantly with how well they did on cognitive tests. So it was his finding there that, it was like microglia activation in the thalamus is seemed to be strongly associated with the level of cognitive dysfunction that you had. And so that's what made us wonder, well, maybe this is something that we can go after with TMS. My read on I don't think that TMS has been associated with changes in peripheral inflammatory markers to the best of my knowledge. I could be wrong about that, but haven't looked at it, sort of uh, uh, much lately. So I would say that we're probably agnostic or skeptical that there will be peripheral signs of inflammatory change or improvement, but what we're hoping for is a brain-specific signal.
It'll be interesting because, my background is very much inflammation, and so I would actually expect it more in TNF alpha and interferon gamma, looking at like sort of longer term inflammation versus acute. I'm curious, does he see the same changes in inflammatory signals in the brain um, in just depressed patients who don't have long COVID?
So we only had a small sample and we didn't have any healthy controls. So we don't know. We can't say based on the literature that we had. What we saw was that microglial activation or microglial activation levels in the thalamus seemed to decrease um, over the time that people got TMS, and that's what made us sort of optimistic about that. So I can't speak to sort of like whether it's present or at a normal level or an elevated level in people with depression. Dr. Ortiz.
Hello, thank you for the presentation. So if I understood, are you kind of the community caring for people with long COVID? Are they thinking of long COVID as kind of a different entity than other post-viral historic fatigues like myalgic encephalitis and chronic fatigue syndrome? And it does seem, I mean, you suggested, Professor Quinn, that you are recommending graded exercise, which I mean, I'm not sure if you're familiar with all of the controversy surrounding graded exercise and post-exertional malaise. So, is in your experience, how has it been? I used to care for people with chronic fatigue, and I used to get a lot of pushback, and I follow the community of the chronic fatigue syndromes that are very active in kind of advocacy as they have been neglected by the medical community. And it's I do feel like it shouldn't be us as psychiatrists dealing with this, but here we are, and I feel like we are more equipped than many other specialties to deal with these problems.
Yeah, thank you, Dr. Ortiz. I really appreciate that perspective because I um, certainly prior to COVID had that same experience. People were referred to psychiatry because there's really felt, you know, this is a problem where you need to either, sort of like uh, work on yourself psychologically or, sort of like just improve your endurance and tolerance and sort of that's going to be the answer. So what I would say is that my take on that recommendation in long COVID feels different. First of all, because like there's a significant spectrum of people with long COVID. So there's people who have pulmonary emboli, cerebrovascular accidents, who have significant signs of like ongoing inflammation, myocardial stunning, clear gut dysfunction. So there's folks with very clear end organ damage. And then on the other end of the spectrum, there's people who had very mild infections, who were never hospitalized and never received any therapeutics for COVID, and then weeks to months later developed this sort of like debilitating syndrome, seemingly, for no reason. So across the board, what I have seen in patients from the long COVID clinic who were referred to cardiopulmonary rehab is that it has actually helped them, and that they say that it helps. That a lot of them were very deconditioned from either just resting at home or being unable to sort of, mobilize or ambulate much while they were sick. And this deconditioning is really sort of can be a really significant contributor to a long COVID picture. So the cardiopulmonary rehab addresses the deconditioning. The poor sort of exercise tolerance that goes beyond deconditioning, that sort of represents this seeming kind of like metabolic disruption where your muscles and your energetics are just not operating the same way as before. That still seems to be there, and that continues to have we have a very difficult time treating that. So and that's where I would say that, if someone had done the rehab and they had improved their conditioning and they've still got this sort of chronic fatigue, and all we're telling them is like, well, you just need to do more rehab, I think they would be frustrated, and I would totally understand why. So that I think there's a component that we feel we can treat with that, and people generally respond to it, and then there's that kind of same kind of more chronic component that is harder to treat. Dr. Hager.
Thank you, Dr. Bartel and Dr. Quinn, for the presentation today. In my reading about the post-COVID symptoms, one of the most prominent symptoms that has come up has been anosmia, dysosmia. And I'm wondering, this is purely speculative, whether or not, similar to in Lewy body processes, I'm wondering if anosmia or dysosmia correlates in any way with the onset of post-COVID cognitive difficulties. And I'm just thinking in terms of also your investigation of looking at microglial activity, Dr. Quinn, because the mechanism believed to be active for the anosmia dysosmia is a glial mechanism as well, with the nasal support cells, olfactory support cells. So I'm wondering if there are tie-ins between those two things, or if smell training has some impact on cognition. Again, purely speculative questions based upon like mechanism of action and so on. So thanks for letting me speculate.
Yeah, I will confess, anosmia has not been my direct focus. It seems a little bit outside of my scope. I would defer to my ENT colleagues around questions about that. What I can sort of say is just anecdotally, people seem to have a lot of anosmia or dysosmia with or without the brain fog going on. For a lot of people, that may have been like one of the only presentations with of their COVID symptoms, and so I suspect that it's not tightly etiologically linked, the link between as anosmia and cognitive dysfunction. So that's just my best guess. I mean, but I invite others to sort of chime in here if they know more, have more experience with it. There are a number of comments in the chat. Let me see if we can sort of get to those. Dr. Price asked about any insights into how this may manifest in children. That's a great question. And I know that there are people who are working on the NIH Recover study involved for pediatrics who are not here on there. I actually haven't treated any kids with long COVIDs, but I imagine that there are maybe people here who are aware of, kids with long COVID. And is there anyone here who has any experience either treating or kind of identifying minors with long COVID or neuropsychiatric symptoms of long COVID?
I'll
Okay,
say I'm
well,
not an expert, but seeing a lot of kids in clinic, I mean, I guess it's tricky because they're just in like these developmental stages when COVID was starting, and it impacted so much of their social life as well. So you tend to hear them just talking more about, people tend to attribute if there's academic difficulties more toward like the change in learning style or social disruption. So I think it's possible maybe some neurocognitive symptoms are getting missed and maybe attributed to other factors. And I don't have a lot of data on this. I just will say we are definitely seeing more pediatric patients who are saying they have POTS since COVID in 2020. But I don't have data or research on that, but that's just what we've been seeing in the outpatient basis.
so interesting. Thank you. And that's such an important point, that the psychosocial experience of living through the pandemic has its own effect on symptoms. And that has to be incorporated into one's formulation. Dr. Holguin asked, there was some early recent literature for SSRIs like fluoxetine for long COVID. Is there still ongoing research on SRIs for this indication? I think those have been shown to not be effective for long COVID, to the best of my knowledge. I think there was also people looking at fluvoxamine, and that also, I believe, has not shown any sort of effect on long COVID. Brant, Dr. Hager provided a reference about the immune effects of theta burst stimulation. Thank you for that. No effect on inflammation. Phew. All right. Good to know. Dr. Pence had a woman who was a runner before having COVID, then got long COVID. She had asthma, but not worse post-COVID. She was done well with low-dose SSRI and starting running again, helped her mental health. So that's great to hear. And I think that, definitely standard treatments also apply in people with long COVID. If they have depression, treat the depression. If they have anxiety, treat their anxiety. If they've stopped doing the things that brought them, sort of were beneficial for their mental health or brought them, wellness or joy, then resurrecting or rehabilitating those activities is important as well. Dr. Manshak, there were early reports of increased incidence of post-viral encephalitis, mostly during times of high prevalence of COVID. Are there reports of association of COVID or long COVID with severe post-viral autoimmune encephalitis? Yeah, that was definitely the case during the initial couple waves of COVID, like the alpha wave and the delta wave. Less so with kind of Omicron related variants. So not to say that it could never happen, but we're just not seeing those cases to the same degree anymore, if at all. And Dr. Wong, famotidine helpful. Yes, famotidine has been shown in randomized controlled trials to help with overall long COVID symptoms. In fact, histamine blockers, whether it's cetirizine, famotidine, hydroxyzine, diphenhydramine, actually, have case report, case series, or randomized controlled trial evidence to support their use in long COVID. So that is actually sort of one of the arms of treatment that I tend to focus on is histamine blockade or histamine recycling. Today, I saw in my clinic the second person who was benefited from diamine oxidase, which is an over-the-counter nutraceutical, which is a histamine recycler. It's usually used in people who have histamine intolerance and have to be on low histamine diets. But I have now several patients who actually said that it helped them specifically with their energy, their brain fog, with kind of these classic long COVID neuropsychiatric symptoms. So I think that there's a whole arm of kind of histamine modulation for long COVID that is definitely one of the treatment approaches that we have. Dr. Delmore, how do we suggest prioritizing considerations for suggested treatments for post-COVID, such as stimulants first, alpha agents? That's a great question. And so usually what I end up recommending or what I talk about is I talk about these different pathophysiologies that could be at play: autoimmune dysfunction, neuroinflammation, physical deconditioning, psychological, kind of demoralization, and just talk about what the evidence shows and what the treatments could be, and produce a menu of options for them. And usually people have quite strong opinions about which items on the menu they'd like to try and which ones they don't. Generally, people do not want to be on stimulants. That's been my kind of the more common response I've seen when I bring those up, because people have all kinds of associations to those medications, and it's generally not something that they want to go straight to. They're much more likely to want to try the nutraceutical and over-the-counter possibilities first. or low-dose naltrexone, which we can compound and have produced for them. And then if they have to, taking a prescribed medicine, which is psychiatric, so Wellbutrin, modafinil, guanfacine, and then stimulants are generally kind of last. They it's only if they have a really pressing professional obligation that they have to meet. Otherwise, they're either going to lose their job or have a serious sort of like consequence for their functioning. Will they say, actually, can I be on the stimulant? So that's sort of the approach that I think people have kind of favored with us. Well, it's 2 o'clock. Thanks everyone for your attention. Thank you, Dr. Bartel, for a stimulating talk and generating all these great questions from the audience here. So appreciate everyone. Have a good rest of your Friday.
Thank you to Dr. Quinn, Dr. Olmsted.